Welcome, everyone, and thank you for joining us today. My name is Connie Choi, Chief Program and Strategy Officer with the National Asian Pacific American Women's Forum, also known as NAPAWF. NAPAWF is the only national organization working to build power with Asian American and Pacific Islander women and girls to create social, political, and economic change for our communities. It is my pleasure to welcome you today to this conversation with our partners in Chicago. Collectively, we are the Reproductive Justice Coalition, or RJC, a collaboration formed in 2023 to address reproductive injustice in Chicago. The RJC is made up of 6 partners: Apna Ghar, Bania Inc., Can Win, Palenque Liberating Spaces Through Neighborhood Action, and SisterReach Inc., as well as ourselves. We are here today to present the findings of a report done in collaboration with the Black Researchers Collective, or BRC, and our advocacy brief, which outlines policy recommendations arising from the report's findings. Founded in 2019, and please, let's go to the next slide. Founded in 2019, the BRC's mission is to advance racial equity by training and equipping communities with research tools to be more civically engaged and policy informed. Before I introduce our esteemed panelists, just a housekeeping item to note. Today's panel is available here on Zoom, as well as being streamed live on YouTube, which means a recorded version will be archived and available on NAPAWF's YouTube channel. Attendees will not be visible in that recording. Throughout the discussion today, if you have any questions, please drop them into the Q&A box. And for those joining on YouTube, you can ask questions into the comments there as well. And we'll save time at the end to discuss your questions. To provide some context as to why we're having this discussion today, for far too long, our organizations have witnessed the impacts of our community's inability to fully access comprehensive and culturally appropriate sexual and reproductive health care. For example, communities of color on the South and West Side experience higher rates of maternal mortality compared to affluent, predominantly white areas. The Illinois Department of Public Health has cited that discrimination, including structural racism, contributed to 39% of pregnancy-related deaths from 2018 to 2020, disproportionately impacting 40% of Black women. These disparities persist despite state-level interventions, including initiatives like the Diversity in Healthcare Task Force, which cites mismatches between healthcare provider demographics and the diverse communities they serve, with Black and Latine communities most underrepresented. Such concerns echo nationwide statistics where 34% of Black, Latine, and undocumented populations have reported difficulties accessing culturally competent care. In fact, 27% of undocumented immigrants report avoiding seeking access to care due to fears of deportation, and over 50% of LGBTQ plus women report fearing judgment by healthcare providers. In addition, the 2022 reversal of Roe v. Wade has also intensified challenges in accessing reproductive health care. While Illinois maintains robust protections through the 2019 Reproductive Health Act, Chicago's role as a regional care hub for out-of-state patients has strained local healthcare infrastructure. So amid this landscape, we felt that it was timely to document and hear directly from our communities about their experiences in accessing sexual and reproductive health care. Without further ado, I'd like to welcome our first guest today. Mekhazen Alexander is co-founder and executive director for Bania Inc. Bania is a reproductive justice and health equity organization focused on serving BIPOC birthing people on the south side of Chicago. Mekhazen has dedicated herself to the betterment of Chicago residents for more than 2 decades. Throughout her career, she has served in many roles, working with infants and children in Head Start programs, youth and young adults in after-school programs, as well as adults and seniors. She is a visionary and has brought the wealth of her experience as a traditional spiritual midwife, perinatal educator, doula, and motivational speaker to her work at Bania Inc. Welcome, Mekhazen. Can you start us off by sharing some context around why the RJC wanted to pursue this research study?
Absolutely. Thank you, Connie. And I'd like to thank our panelists. I'd like to thank NAPAWF for putting us all together, as well as our audience who is joining us today. And so for us, we wanted to center this research on how BIPOC women, birthing people, and our LGBTQ communities define access to reproductive justice. And we want to look at those barriers, specifically to reproductive health care in Chicago and in those communities where we reside. And we really represent a very diverse group. And so it was important for us to look at what those barriers were in those communities. And then ultimately pulling this research together to look at what policy changes we can make and look at those changes as real solutions to the barriers that we are finding.
That's really helpful stage setting for our audience today. Can you also share a little bit about the report process? How did
Absolutely.
That'd be great. Thank you.
Absolutely. So when we looked at coming together, and there are a lot of resources out there, and through surveys and just questionnaires, and we felt it would be really good to have listening sessions. So we came together over the summer last year, and we thought it'd be very impactful if we got a group of at least 7 people to come together for 90 minutes and just talk about what they were experiencing. And so we had 98% of women who participated, 2% non-binary. We had people, 35% Latine, Asian American, 33%, and 25% African Americans that participated. And in that population, 58% were US citizens, 57% were parents. Interestingly, 73% were insured, and we looked at the median income of $20,000. And 60% of our participants had bachelor's degree or higher. So the next slide, reproductive justice. So there is a broader definition, but for our purposes this morning, we know that reproductive justice is the right to maintain bodily autonomy, the right to have children or make a decision not to, and the right to parent in safe, sustainable communities. And this should be inclusive of women, regardless of gender, gender expansive people, and our LGBTQ plus communities.
Thank you so much. Yeah, that's actually the definition, right, that we chose to use when putting this report together. Turning to the report itself, can you get us started by sharing some of the high-level findings of the study? What were some of the broad takeaways?
Absolutely. Let me just say that, we're doing this because we want people in the community to know why this actually matters, because it matters to make sure that people, if they aren't aware, they are made aware of all the systemic barriers that people face as it relates to attaining reproductive health care. And through this study, we're hoping that we can equip policymakers to make real changes, advocate for change in the communities that they actually serve, um, and ensure that everyone has access to reproductive care, that individuals who seek it feel empowered, they feel that they can advocate for themselves, and they can make the best decisions possible for their lives and the lives of their families.
Thank you. And then, yeah, well, if you could share kind of what some of the high-level findings were, that would be great.
Absolutely. So overall, in our findings, to summarize it, we found that communities cited they face violations of bodily autonomy. And when it came to the type of care they received, they felt it was due to racism, ageism, classism. A lot of cases they found inadequate access to reproductive health care as well as information. And they didn't feel safe. They didn't feel safe that their communities were sustainable and a community where they felt safe raising their own children. And this is an approach or systemic causes that has been existing for a really long time in the communities that we actually serve. And so we know that if we invest in the right type of access to reproductive justice and healthcare, it will enforce protections against the discrimination and invest in the community so that we can have these viable solutions that are needed as it relates to reproductive justice. I'm going to go to the next slide and talk about the key barriers, which in Chicago, BIPOC women and birthing people and LGBTQ plus communities face structural barriers. We talked about racism, economic inequality, immigration status, their language and cultural barriers, healthcare gaps, and education gaps.
Thank you so much, Ms. Cousin, for those insights. We'll welcome you back to the Q&A section shortly. Next up, it is my pleasure to introduce someone that I have the pleasure of working with every day. Fejer Saeed Ibrahim is Senior Policy Manager at NAPAWF. A lawyer by trade, Fejer is a skilled advocate with substantial experience in organizing research and policy related to reproductive rights and justice, racial equity, survival justice, and immigrant health care. Before joining NAPAWF, she has worked as a senior advisor with the Coalition to Expand Contraceptive Access, a consultant with the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, and as state policy counsel and consultant with the Center for Reproductive Rights, just to name a few. Please join me in welcoming Fejer to the panel. So Fejer, we now know what brought our coalition partners together and the high-level takeaways from the study. This is a qualitative report rich with personal experiences. Can you delve in deeper into the findings of the report and share what the participants' experiences have been?
Yes, thank you so much, Connie, and hi, everyone. I just want to start with saying that while I'll share key findings from our research today, these are by no means the full scope of what we uncovered. Strong plug for you to read the full brief to truly just fully grasp the depth and the nuance of the data. Our findings really illuminate critical barriers like the persistent inequities and the resilience of those navigating the reproductive health landscape in Chicago. And what I'll highlight today are insights that underscore why policy interventions have to be as multifaceted as the communities that we all seek to serve. So as Mekazin already covered, and as Connie earlier covered, reproductive justice is more than just the legal right to abortion. It means the right to have children, not to have children, and raise our families in safe and supportive environments. And for many communities in Chicago, these rights are deeply restricted by racism, economic inequality, immigration status, and systemic neglect. Our research found that Black, Indigenous, people of color, BIPOC women, birthing people, and LGBTQ plus folks face overwhelming barriers to reproductive health care and family well-being. And if we can pull up the slide that we ended on, just to quickly go over these again. So many experience structural barriers, whether it's the impact of racist healthcare policies, economic instability that limits access to care, or immigration status that blocks them from vital services like Medicaid. There are language and cultural barriers, a lack of interpreters, culturally sensitive providers, and respect for diverse health needs leads to misinformation and general fear. Then the healthcare itself is failing our communities. Limited Medicaid expansion leaves people uninsured, and there's a glaring lack of providers who reflect the communities they serve. Patients don't see doctors who look like them, who speak their languages, or understand their lived experience. Finally, education gaps make it harder for folks to make informed decisions about their reproductive health. Chicago still lacks comprehensive sex education, leaving young people specifically without the knowledge they need to navigate their own care. And these barriers don't exist in isolation. They compound, pushing communities further into cycles of medical neglect, economic insecurity, and reproductive oppression. And this reality shapes every aspect of healthcare access in Chicago. Next slide, please. So First, participants reported widespread violations of bodily autonomy and dehumanizing treatment in healthcare settings. Racism, classism, ageism, ableism, and transphobia all shaped the way people were treated or mistreated when seeking reproductive care. So half of the participants, 1 in 2 people we spoke to, shared experiences of discrimination or mistreatment in medical settings. Black participants specifically described the feeling like test subjects, that's a direct quote, receiving subpar care compared to white counterparts. Young people seeking permanent contraception were denied their right to make decisions about their own bodies, told they were, quote, too young to know what they wanted. And then low-income patients were rushed through appointments, treated with a kind of coldness, and in some cases just outright dehumanized. One of the most harrowing stories we heard was from a Black mother who was slapped and pinched by nurses during labor. The nurse later admitted that this type of treatment was common. And another participant shared how during childbirth, a nurse mocked her pain, saying, again, direct quote, "You had no complaints during intercourse, but now you're screaming." So just really horrific stuff. For trans and non-binary people, the barriers were just as steep. One participant described avoiding the doctor entirely because every visit came with misgendering, with invasive questions, and outright hostility. This is obvious to those of us, I think, on the call, but no one should have to weigh the risk of harm when seeking medical care. But this is the reality for far too many. Next slide, please. So even when reproductive healthcare was technically available, people still faced financial, geographic, and systemic barriers that made it nearly impossible to access the care that they needed. So participants noted that there were too few clinics providing comprehensive reproductive care, making contraception, abortion, and other services really hard to get. A lot of participants, especially low-income and undocumented individuals, couldn't afford reproductive healthcare services because of insurance restrictions or high out-of-pocket costs. And even when some participants did receive contraception, many weren't informed of side effects or given alternative options, and that led them to completely mistrust their provider and the healthcare system as a whole. Lack of information and access also led to coercive dynamics. Some participants were pressured by doctors into taking birth control they didn't want. Others were denied procedures they did want, like tubal ligation. One woman shared her abortion experience was cold, painful, and transactional without care, compassion, or real options. And again, no one should have to fight this hard for really basic healthcare. And what we know is that these barriers don't exist in a vacuum. So cultural taboos and misinformation further exacerbate the issues. Many communities, particularly immigrant communities, struggle with entrenched stigmas around reproductive health, creating a general environment where folks are discouraged from seeking care at all. Participants spoke about bringing fear or fearing bringing shame to their families, and that hesitation was reinforced by media portrayals that fail to depict diverse and affirming reproductive experiences. Next slide, please. Finally, what I want to emphasize from the findings and what we already know is that reproductive justice doesn't end with pregnancy or abortion. It extends to the right to raise children in safe, healthy communities. And many participants told us that the conditions in their neighborhoods make that nearly impossible. So Black parents feared for their children's safety, not just in their communities, but from the police in general. One mother told us that her 3-year-old had been having nightmares about being shot by the police. And that's just a reality for far too many Black parents every day in this country. So Chicago is no different. There's also a lack of affordable childcare and workplace discrimination, which makes it harder for working class parents to balance caregiving and financial security, attain financial security. Trans parents and queer families specifically shared how discrimination made it harder to access fertility services, adoption resources, and parental rights protections. And then women and gender expansive folks talked about feeling unsafe simply moving through their daily lives. So one participant stopped taking public transportation after nearly being physically assaulted on the train. And this is really highlighted by one of the quotes. One mother, she put it very simply. She said, "We're not safe. Women are not safe." And what we know is that physical safety, or safety in general, isn't just about physical violence. Economic insecurity, lack of paid leave, and unsupportive workplaces force many parents, but especially immigrant and undocumented parents, to choose between putting food on the table, staying home with a sick child. That's true for low-income folks more broadly, and that's just not reproductive freedom. So if we're looking at the findings as a whole, and again, there are many deeply, strongly encourage you to read the brief, but reproductive justice in Chicago is deeply impacted by systemic and structural barriers that are rooted in racism, classism, sexism, and ableism, other intersecting forms of oppression. And these barriers manifest in restrictive policies, societal norms, and cultural beliefs that limit access to care, to information, and to autonomy. I didn't cover this at length, but can certainly do so during Q&A, but cultural barriers, so everything from conservative gender roles, religious beliefs, stigma, discourage open discussions about reproductive health, and that leaves many without critical information and support. Participants in our research described how fear and shame prevent them from seeking, again, contraception, visiting doctors, or even talking about their periods with their families. And then medical mistrust, particularly among Black and Latine communities, further compound these challenges, as does the lack of culturally sensitive and language accessible care. And then economic barriers create significant obstacles. So job insecurity, high medical costs, and inflexible workplace policies force people to delay or forego reproductive health care altogether. And for many, affordable, childcare or taking time off of work for medical appointments is just not an option. The last thing I want to emphasize is that these barriers are not accidental. They stem from policies that have systemically excluded and marginalized communities of color in Chicago. Redlining, housing discrimination, and economic disinvestment have left entire neighborhoods without access to quality healthcare, to safe housing, and to any form of financial stability, which only further entrenches reproductive injustice. Back to you, Connie.
Thanks so much, Pleasure. We look forward to chatting more with you during the Q&A. Our next panelist is Cherise Scott, CEO and founder of SisterReach, Inc. Cherise has spent more than 20 years as a passionate educator, advocate, and leader in the reproductive and sexual justice movement. Her journey began as a patient seeking reproductive and sexual health care, who found herself in what she would later learn was a pregnancy counseling center, posing as an abortion clinic. That experience was pivotal for her, seeking and being embraced by a movement led by Black women committed to empowering, educating, and mobilizing people who deserve unhindered access to comprehensive reproductive and sexual health education and care. In 2022, Cherise founded SisterReach Illinois, which is the only Black woman-led RSJ organization in the state. SisterReach empowers those they serve to lead healthy lives, nurture healthy families, and thrive in safe and sustainable communities. Thank you for joining us, Cherise.
Glad to be here.
Can you share with us what are some of the ways that Chicago can model how local leadership can and should fight for reproductive justice?
Absolutely. And I'm so excited also to be a part of this wonderful panel. And for all of the time that we've been working together, it has really been eye-opening. And I'm so excited for NAPAWF's leadership and inviting us to be a part of this important work. And so when thinking about advancing reproductive justice at the local level, the city of Chicago can enact the following changes. It's really important that there is an emphasis on expanding Medicaid access for all, regardless of their immigration status, to strengthen language access and cultural competency and humility standards, to invest in inclusive, community-based, comprehensive reproductive and sexual health education, to enforce protections against healthcare discrimination, and to create a Chicago Reproductive Health Equity Fund to support services and access workforce diversity.
Great. Thank you so much. Actually, and can we do the next slide, please, which kind of outlines what Cherise had mentioned?
Right. So let's go a little bit deeper into those key policy.
Oh, are folks hearing Cherise?
No.
Ensuring equitable access for all.
Cherise, I think you're freezing up a little bit. Oh, looks like we're having some technical difficulties, as always, during a Zoom webinar. Let's see if we can get her back on. I think in the meantime, what I can do is, Ferdinand, can you go back to the previous slide, please? And let's talk a little bit more about kind of the key policy recommendations. One of the things that we as a coalition decided was really trying to parse out what are some of the changes that we wanted to see at not only at the Chicago level, but also at the state and federal level. And these are the five primary kind of policy changes that we wanted to specifically highlight. And given the comprehensive kind of nature of concerns that came up during the conversations that we had with our seven focus groups, really throughout the city. And so number one was universal healthcare coverage, as Cherise mentioned. And we wanted to specifically push for expanding Medicaid for all, regardless of immigration status. One of the ways in which that we found not only difficulties with regards to expanding, with regards to, hi, Cherise, are you back?
Yeah.
I've been trying to be a poor woman, Cherise, as you dropped off. So I think we had started the conversation a little bit more about delving into Chicago level changes that we wanted to see. So I'm wondering if you can kind of get us started there.
Sure. And so that Chicago level again around that universal health care coverage. And I just want to make sure I know exactly where you were. Were you at universal access to sexual and reproductive health care education?
Mm-hmm.
Okay, awesome. So again, we want to make sure that it's comprehensive, scientifically accurate, culturally responsible, and ensure key topics include bodily autonomy, sexuality, comprehensive sexual and reproductive health, safe and healthy sexual relationships. And that includes information on consent and navigating scenarios that may be challenging around contraceptive use and tools that support sharing sexual health statuses. And then we want to also center comprehensive social safety net programming that transforms societal conditions and listens to those who are most impacted to inform what programs should be prioritized and best practices to navigate those programs, enabling families and communities to exercise greater autonomy over their health and well-being. And lastly, our community-driven framework that centers the lived experiences in reproductive justice policies, ensuring that those doing research reflect the communities that they are researching, considering those who share their lived experiences as equal partners and consultants with the mechanisms for ongoing oversight and accountability to do that work.
Great, thanks so much, Cherise. I think, can we go to the next slide? And so specifically for Chicago, just to kind of talk about, the broader changes that we want to see, can you talk a little bit more about what can happen within the city?
Sure. So city and state leaders can make it easier for women and gender expansive individuals of color to access high quality reproductive care by prioritizing policies that prevent discrimination in healthcare settings and respond to patients' cultural needs. For example, federal protections for reproductive care were never enough. And now, as they come under attack, the responsibility falls even more heavily on states and cities to safeguard and expand the funding that makes essential care accessible. So the city can model how local leadership can and should fight for reproductive justice by removing those important barriers to care.
Thank you so much. Let's talk about the other tiers of government. What are the policy changes at the state and federal level that could help alleviate the barriers that prevent women of color from living full, healthy lives and empower them to assert their own agency?
Mm-hmm. So the state of Illinois can enact the following changes that we recommend, which is defending and expanding Medicaid access, enforcing language access and cultural humility standards, invest in inclusive community-based reproductive and sexual healthcare education, strengthen protections against discriminations in healthcare, and then again, establish a Chicago Reproductive Health Equity Fund that we can even translate into the state level, that we also think is really important, so that there can continue to be that level of oversight, so with that there can be guidance, so that you have a consistent way of having that information from the ground to the state level and passing policies that are going to impact people in mass.
Awesome. And then what can happen at the federal level?
Absolutely. And then contraceptive equity is really important. And, you know, I know that there is an emphasis on IUDs and birth control, but we meet the full range of contraceptive access. That includes access to barrier methods of contraception, person control methods of contraception, as well as provider control methods of contraception, because they all play an important role in the health and wellness of people who are navigating their sexual lives. Comprehensive reproductive and sexual health care education as a federal policy of access, right? So that we don't have the types of barriers to access that on the state level, but even the implementation of that sexual health education. It doesn't necessarily help us, right? If we pass laws on the state level or on the federal level that never make it to the ground. And so then accessible and affordable abortion care. We know what we are up against. We know what this looks like. But what does it look like if we lost that access on the federal level? What are we actually prepared to do to support people who are navigating and need access to abortion care? Then gender affirming care, right? So making sure that that folks of trans experience, folks who are gender expansive, have that level of access without fear of bias, doing cultural humility and patient-centered care trainings with providers, making sure that even on the medical level, medical school level, that folks get that type of education that they need. And then access to healthcare also for all, that is not just universal, but accessible regardless of your immigration status. If you are on US grounds, you ought to be able to access healthcare, and that's just a human right.
Thank you so much for your insights, Sharice. I think we have, we're now going to be pivoting to the Q&A portion and open up the forum for audience questions now. If you haven't dropped your questions into the Q&A chat, please do so. And I think I'm going to start with this first question that I'm seeing in the chat box. I'd love to hear more about why and how you chose Chicago as a case study for this research. What is unique about Chicago and Illinois, geographically, politically, and socially? I'm wondering if Fejer, you can get us started with this.
Yeah, thank you, Connie, and thank you for that question. So I think Chicago was chosen because it offers a unique intersection of progressive reproductive health policies, demographic diversity, and a strategic geographic location. Illinois has some of the strongest reproductive rights protections in the country, where abortion is enshrined as a fundamental right, and there are laws that prohibit discrimination based on reproductive health decisions. So that makes it an important place to examine how policy can serve both as a safeguard and as a model, especially as neighboring states impose severe restrictions. But what's interesting is that, I think Chicago also shows that strong policies alone aren't enough, right? So when you look at BIPOC communities, they still face significant barriers to reproductive health care, from, language access and cultural stigma to gaps in, say, immigrant inclusive coverage. And what the research shows is that even in progressive cities, communities can be overlooked, and policy has to be intentional in addressing their unique needs. So I think Chicago's diversity really offers key lessons on where the protections are working, where the gaps remain, and then how to make sure that reproductive justice is actually inclusive.
Thank you. And I don't know if Sharice, if you wanted to add some additional thoughts here as well.
No, I think that's wonderful. Thank you for sharing.
Sounds great. I'm seeing another question with regards to, and I think this might be good for Mikhazen. What other organizations in Chicago, Illinois, and the Midwest support this work, and how can we support them?
Well, first, let me say that, in spite of we call Chicago and Illinois a safe state, in which it is, regardless of what's going on in the other parts of the country, people know they can come to Chicago and then get support, for their reproductive health care. But one of the things, in spite of all of that, we're still looking at something called the 5 A's of access. So through the research, the systemic racism, there's still issues with affordability, availability, accessibility, accommodation, and acceptability. So people are still working through those barriers. But in terms of who else is out there, there are several organizations that are aligned with this work. I'm going to give a shout out to the Chicago Foundation for Women, who has formed an organization called Reproductive Justice Champions. It is led by Dr. Toni Bond. She is the founding mother, one of the founding mothers of the reproductive justice movement that actually started here in Illinois. And the group of organizations there, like we are, a diverse group that are working with other organizations to make sure that these systemic barriers and access to healthcare are solved on some level, right? Through policy, through working in the community, to working on the local, state, and federal level. So you have organizations like Sex Expectations, who is actually in the school systems, and they are teaching young people about contraceptives, safe sex, safe dating. There's Rebirth Society, where they are also teaching young people about systemic barriers and how they can work with not only young people, but their families. So there are several organizations. There's BANIA. There's several organizations out here that people can actually volunteer, network with, help to push some of the policies. So we can all work together, because together we're stronger. And so join us, work with us, because the work continues. The work is good work. And so we want to be inclusive. This is this report that we did is so that people are aware of what is happening in Chicago, what's happening in Illinois, and we are open and receptive to anyone who wants to help uplift this work.
Thank you so much, Mikhazen. I think this question might be perfect for Sharice. While there is a dearth of medical professionals who look like us, quote unquote, there is no guarantee that BIPOC medical professionals are culturally competent or understand cultural humility standards. Are there specific programs that address this?
Absolutely. So I've had the honor and privilege to do a patient-centered care implicit bias training with Dr. Christine Dellendorf out of the University of California in San Francisco. What we learned by putting that work together and bringing that reproductive justice analysis to her patient-centered care analysis that is informed and driven by the reproductive justice framework is that regardless to race, right, we still have several providers who just don't get it. One of the things that we have pushed and that I continue to challenge providers on is even the tiered effectiveness model that the CDC says around contraceptives, right? What is most effective versus what's not most effective? The unfortunate part where we see a hierarchy disparity, where we see a race and class disparity, where we see kind of racism creep into the ways that healthcare provision is happening, is that what is being prioritized as most effective are the methods that providers control. not necessarily the methods that the person controls. So it's not necessarily that condoms don't work, it's that the person who's using the condom doesn't know how to use it properly. It's not necessarily that an IUD is more effective. It can delay pregnancy for a long period of time, but that doesn't make it more effective, right? I think we need to really weigh what we are considering, what is most effective versus do we trust the people who are using the methods that of their choice. And if they don't have the proper education about what that method looks like, then whose responsibility is it to make sure that they do? So we always put the onus back on the provider. So I recommend, as I'm sure Dr. Dellendorf would appreciate me saying in this webinar, that a patient-centered care framework absolutely must be adopted by the medical care community, and it needs to be undergirded by all of our medical associations, right? And and we are available to continue to do that training with folks who want to do that. So please feel free to reach out. We're happy to schedule time to do that with whomever and to bring that type of education and knowledge, not just to doctors who are already doing the work, nurse practitioners, midwives, doulas that are already doing that work, but those who are in medical school, which is why I think that our research that we're giving today is so important. And it's going to be, and I think it opens up a broader conversation about having more of an intersectional, not just an analysis, but a strategy on the ways that we can best serve folks.
Thanks, Sharice.
Can I add to that?
Sure.
I just wanted to add to that because Sharice really touched on something. We do need to have this conversation with medical providers so they understand that, we are in line with them, in alignment with them. BINEA has embarked on a program. It's called Inclusion, Diversity, and Birth Equity Training for Hospitals. And we really are attempting to work with the medical team to let them know that we're here to support them as they support people who are coming in their doors for services. And it has been a struggle because there are hospitals and doctors who don't want us in those places, but we need to be in those places because we best know how to support our community. We best know what our community needs. And so if we're in those spaces working with the medical team, we actually can help reduce a lot of the infant and mortality and maternal mortality that's occurring. So I think, it's important for all of us to understand that together we can work through these issues that we're finding and at the end of the day, solve them in the communities that need the support. And then additionally, we need to do the education in our communities because our communities don't have enough information about what their choices are and how they can advocate and empower themselves.
Thank you so much, my cousin. I don't know, Fezra, did you also want to add to this question as well?
Yeah, those answers were so comprehensive, so I'll keep it super brief. But I just, again, wanted to strongly +1 on community-driven efforts and partnerships between medical schools and community organizations, like the ones that we noted in our presentation, to just help ensure that training reflects lived experiences and community needs. And then I think the only other thing I would say is that it's not just about training. There also need to be systems of accountability to make sure that, cultural competence is embedded in practice and it's not just theory. So that means ongoing education and patient feedback mechanisms, and then also bolstering that with institutional policies that really prioritize both culturally and linguistically inclusive care. And shout out to 2 organizations that do some of this work. So Physicians for Reproductive Health, for providers out there who want resources, and then also Medical Students for Choice.
Thank you, Fezra. I'm going to kick things back to you for this next question. How can we push for these changes on local and federal levels, especially in our current political climate?
This is a really easy question. And I'm making eye contact with fellow panelists who may want to jump in. But yes, it's a difficult environment we're operating in. But in some ways, it's always been a difficult environment for our communities, right? Like I think a lot of folks would argue that, and I'm especially thinking about BIPOC women and LGBTQ plus communities and birthing people who've always had some level of precarity that they've lived with. But yes, it feels especially difficult right now. I think if we're looking at, how to push for change, both at the local and federal level, it requires really a mix of strategic advocacy, responsible and community-based coalition building, and then just political pragmatism, especially in today's climate. So I think at the local level, wherever you're at, engaging directly with city councils and state legislators and then public health agencies feels really critical. What I'm thinking about is policies like funding for language accessible healthcare, expanding Medicaid coverage, and then protecting abortion access. They often gain traction faster at the state or municipal level. And then again, just grassroots mobilization feels really, really important. It's always been important, but especially now. And I think, things like partnering with ethnic media for immigrant communities, hosting community forums, and really leveraging local data that can make these issues harder for policymakers to ignore. If we're looking at the federal level, which is where my work is based, the general thing I can say is progress may feel slow, but we can sustain pressure, and we know that sustained pressure works, right? And I think for me specifically, what I'm looking at right now is pushing for policies like the HEAL Act and the EACH Act. There's more information on both of those on our websites. Protections under Section 1557 of the Affordable Care Act. So that whether that's through coalition efforts or congressional testimony, but what's really pushing for these visionary bills that may not move right now, but we have movement work is a long haul, long-term strategy. So we're looking at making gains right now that set us up for success years from now. I think I'm trying to think if there's another thing to highlight. I think the one other thing I want to note is just narrative power feels really important right now. So changing the conversation so that communities of color, gender expansive communities are not overlooked in reproductive justice fights. And that means that the more that we make our communities visible, the harder it is for policymakers to sideline us.
Thank you. Sharice or Mikazin, do you have any additional thoughts to share? Mm-hmm.
Running to state-based organizations, what often happens is that the state and federal folks go ahead and create the strategy and leave the state people out of it, those who are on the local level doing the work. However, the folks on the state and federal level often do not have that level of information. They don't have it in an in-time cadence, right? And so just because, right, you may have the most lawyers, just because you might have the lobbyists, that doesn't mean you have the education, the information that is important to kind of make the case, if you will, right? So I often, push back on national groups coming into the state to do work because they don't normally do it in the ways in which NAPAWF has held this coalition together, right? Not just trying to lead the work and do the work, but bring people who are doing the work on the ground to be a part of what that looks like, to ensure that we didn't miss anything, right? And not necessarily assuming because you have the national resources, because you have the national access, because you have access to the legislators, because you have access to the lobbyists, that makes you the best messenger. It's not necessarily that you become the best messenger. What looks like, what is the best messenger is the person with that lived experience. If you're fighting for HIV and you're not living with HIV, you're not the best messenger to talk about HIV. You need to work with someone who's living with HIV and work with that person. If they are not equipped with the information, they're going to bring the passion, they're going to have their lived experience, and then you bring the policy savvy in. You bring that the relationships that you have with those legislators. At the federal level and at the state level, who might be the best legislator to try to move a piece of policy through or move a piece of policy with. But that's all you have, right? So I think it's really important that it's not just a federal and state type of strategy, but it is also that we're working with folks, not just even groups like mine, right? But those groups that never get any information, never get any shine. These are the coalitions. These are the folks that are in church ministries. These are the people who are doing neighborhood work. Those are the gatekeepers, right? And so, but the state-based groups that's who we work with. We work with those folks intentionally, and most times, folks who run state-based groups are the people that they serve, right? So that's that's our tagline at SisterReach. We are the people that we serve. So every element of the work that we're doing, both in Chicago and across the state of Illinois, both in Tennessee and across in Memphis, is because somebody on my staff either has lived experience, has 1 degree of separation, might be taking care of somebody with that particular experience, may have had that experience in the past. I come to this work as a client, right? I came to this movement as a client. And it is because of that, it is that lens that I do my work. It is that lens that I advocate. It's that lens that I push back with, right? I come with my race, class, gender, orientation, all of those things. And so I think that it's really important to add to what Fajr was saying, to bring also that important element to the conversation, not just as something to kind of siphon from, but to legit have those folks at the table to help with strategy and decision making, and to inform what policy needs to look like.
Thank you, Sharice. So I think we have time for just one last question, which I think is actually apropos for this conversation, which is, what recommendations or lessons learned do you have about conducting community engaged and led research? And so I'm wondering if Mikazen, if you can get us started with this question.
Certainly. I think now more than ever, more research is being done on the community level, because people want to know. Research in the past, we were left out of it, and then we were told what it would look like for us. So once you have, local community, engagement, and you have research by people who look like you, who understand you, then you have a better platform in which to work out of. And so I always think there's this line, because Sharice hit it right on the head, but there's this line that says, just give us the resources and just move out the way, because from there we can do what needs to be done. So it's been, a great process for us to be included and to be at the table, because if in fact we are the ones suffering, if in fact we are the one going through these issues, then, as we're all saying, we need to be at the table to decide what will work best for us.
Thank you. I don't know if Sharice or Fajr, you want to add to that?
Yeah, we do research, and we do it intentionally because I wasn't happy with what I was seeing coming out of the institution. I was seeing folks who didn't look like Black communities, not just doing the research, but kind of just siphoning information from folks as if those people are not the experts. Folks are the experts of their own lives. And so when we are doing even this project, it was really important to not just center folks and to pay folks a couple dollars, but to give folks a substantial amount of money for their time, because they are consultants at this point, right? And to treat folks as if they are consultants. And so that's why we lead our own research anyway, because we recognize that, just giving folks a couple dollars, $25 gift card that they can't access, that they can't use, isn't helpful, right? And then you write this, robust research, and you get thousands or millions of dollars to do that work, and none of that money goes back to the ground. And so not just doing that, but also offering recommendations from folks who have given you their time, because we have our recommendations as the organizations that do this type of work, but then there are the recommendations from the participants themselves. So it's really important. What you see a combination of in the research in that full report is a combination of our analysis, the analysis that came straight from our participants that participated across all of the organizations that led the research, because we wanted to make sure that you got exactly what you needed to hear, not not a part of what you need to hear, so that we can solve this once and for all. We can't quell this with an approach that isn't culturally, that isn't embedded in cultural humility, that constant evolution. You learned it last year when things change. Now we're under a different administration. There's a new strategy, there's a new issue, there's a new impact. So you got to go learn again, and you got to make space for that, professional development for that, and investment for that also. Mm-hmm.
Yeah, just a strong +1. I mean, I think community engaged, or honestly, even better, community-led research requires a fundamental shift in how we think about and approach knowledge creation. So a strong +1 to Sharice's point that humility is paramount. Fair compensation really is a non-negotiable. So moving away from tokenistic payments and really just reflecting the true value of communities' contributions. And then I think the only other thing I would add is that data ownership has to reside within the community. So that means that communities have to have control over how their data is collected, used, and disseminated. And researchers need to be transparent about how data sharing practices work and get informed consent from their participants.
Thank you. So I think we're at time. I just want to thank all of our panelists today, as well as our partner organizations, Apna Ghar, Canwin, and Palenque LSNA, who participated in this process with us. And thank you to the BRC for their collaboration, for their research. And thank you to you all. We appreciate all of you joining us here today and for your participation and engagement. To stay up to date on future events like this one, as well as other issues that are impacting API women and girls and gender expansive individuals, please sign up for our mailing list. I'm just going to do a very personal call out for our organization at napawf.org. We are planning some exciting events and activities in the next coming months, including for AA and HPI Equal Pay Day in April, as well as Asian Pacific American Heritage Month in May. So please be on the lookout for additional details in your inbox and across our social media channels. Take care. Thank you so much for joining us, and we hope that you have a good day. Bye.